Good evening and welcome to our show Healthy Life. I am your host Dr. Isa Al-Gnaim, and with me Dr. Dalal Al-Aradi. Today we'll be having two guests. Will be with us Dr. Mahmoud Alfeeli, consultant nuclear medicine in Jahra and head of department in Jahra Hospital, and Dr. Abdurrahman Al-Anazi, ENT resident in Al Jahra Hospital. So if you have any questions or would like to participate in this episode, please don't hesitate to contact us on the following means.
Welcome back. My name is Dr. Dalal Al-Aradi and I'm co-hosting tonight with Dr. Isa Al-Gnaim. So introducing our first guest for tonight, Dr. Mahmoud Alfeeli, who's a consultant in nuclear medicine department and the head of the nuclear medicine department in Jahra Hospital. Good evening, Dr. Mahmoud, and thank you very much for accepting our invite to our show tonight.
Thank you very much for having me here with you.
All right, so we'll start with our first question, Dr. Mahmoud. We're just trying to introduce to our viewers, what is nuclear medicine and basically what does it compose of?
Yeah, and nuclear medicine is a diagnostic method and also treatment, but it relies on the function and the physiological function of the patient rather than the anatomy. So in contrast to radiology, where radiology rely on the anatomy of the organs, we rely on the function of the organs. And we use radio tracers, which we inject either into the patient via the veins, or the patient can take them orally, and we inject a very little amount of, a tracer amount of radioactivity, which will go to a specific organ, and then using gamma cameras or PET or positron emission tomography machines, we can image the patient and deduce the function and also the anatomy of the specific organ that it is being tested. Also, nuclear medicine, it is used in treatment of certain diseases like Graves' disease and hyperactive thyroid. Also, it is used in treatment of some tumors. And also, it is used in that we can use also nuclear medicine to treat inflammatory conditions like in the knees in Kuwait. Of course, outside they can treat almost any joint. But here in Kuwait, because it depends on the radio tracer which is used, and the one which we have license here in Kuwait is only allowed for knee joints.
And Dr. Mahmoud, if we want to be more specific on the uses of nuclear medicine here in Kuwait, what is available usage of this?
In Jahra Hospital also.
In Jahra, to be more specific.
Well, in Jahra and also in almost all of the Kuwait, the bulk of our work in the nuclear medicine department, like 50% of our work is cardiac studies. We do stress and rest imaging for the patients, and the test is usually ordered by cardiologists or surgeons to diagnose whether the patient has ischemic heart disease or not. And the second largest test that we do is for nephrology. We do renograms, in which we test the function of the kidneys. We also do a test to image the morphology of the kidneys and if there are any scars because of UTIs, urinary tract infections. The third most common test is thyroid scanning. We do thyroid scan and uptake, and usually with patients having hyperactive thyroidism or thyroid nodularity. And then there are also more tests. We also have bone scans, in which we do it for either bone infection if there is osteomyelitis or if there is septic arthritis. It is also used in oncology to detect bone secondaries. We also have tests. We use carbon-14, in which we use it as a urea breath test, and it is also done for a patient with dyspepsia or gastric upset, and we can detect whether there is H. pylori bacteria present, and this, because if it's treated, then the patient will be symptoms-free. There are also tests for parathyroid adenomas. We also have tests for, we do HIDA scan, in which we test for the biliary function of the liver. We also do studies for liver hemangiomas and multiple other studies. We also have studies for like suprarenal glands and like in case of conditions of pheochromocytomas and other endocrine diseases.
So all of those are basically, a lot of them are diagnostic. We're
Yes.
just diagnosing the disease.
Yeah.
What is the role of nuclear medicine in treating
Yeah, for treatment,
diseases?
in Jahra Hospital, we treat hyperactive thyroidism. So benign hyperactive thyroidism disease, it can be treated in Jahra Hospital. If the patient has like a grave disease or toxic nodular goiter or toxic multinodular goiter, after the diagnosis using the scan and uptake, usually we cooperate with the endocrinologist, and then it will be a combined decision, and then we can offer the patient the treatment with radioactive iodine. Then the patient should come to the department. Of course, we will calculate how much dose the patient needs, and will be given a specific dose, which will be requested from the Central Radiopharmacy, which is located in Kuwait Cancer Control Center. And then that specific dose for that patient will come to our department. We call back the patient. Of course, we give him instructions, because with treatment there should be some instructions for the patient to avoid exposing the members of the family for the radiation, because radioactive iodine has two types of radiation. It has gamma ray, which is used in imaging, and it has beta radiation, which is used for the treatment and to destroy the hyperactive cells in the thyroid gland. And after the patient receives the dose, he goes back home, and usually the instruction we tell him to sleep in a separate room for 3 days and avoid public contact on those 3 days, and then after that he can practice his normal life. Of course, 2 months later he should continue following up with his endocrinologist to do thyroid function test, in which the hyperfunctioning tissue of the thyroid gland will be starting to come down. It takes about 6 months to go back to either normal. Most of the patient will become below normal, and then they will require replacement therapy with L-troxine tablets.
All right.
So, doctor, upon referral from our side to the patient to your department, what is the process they go through? I think we have a video that will accompany your comments.
Yes. This is a patient coming to our department with the request. He will hand it over to the technologist taking care of the reception and arranging all the appointments. They will be they will hand over a sheet of instructions to the patient, whether to be fasting or not fasting, and what medication to stop or what medication to take prior to coming to our department. Of course, this is the room where we do the stress test, and it has a treadmill machine. It also has a bed, and we have an infusion pump, because we do the stress in 2 types. Either the patient exercise on the treadmill, or the patient will do a pharmacological stress test.
Does that affect the result of the test? If the patient was able to do the exercise versus patients who can't, and they do the one with the drug?
It
does
doesn't.
that affect the
No, it doesn't
results?
affect our test. The imaging is not affected by that. Usually, we actually in nuclear medicine, we prefer to do pharmacological test over doing the treadmill.
Test.
Of course, but during doing that, usually a cardiologist will be present, and cardiologists prefer to do treadmill test, because then they can rely on the ECG that they did. But if they do a pharmacological test, then usually the ECG is not that diagnostic.
Okay.
So here we see the patient blood sample.
The patient goes to an injection room. He will receive the injection, and then after that will be taken to the imaging room, where the patient will be put on the imaging table. And if it's a cardiac study, we'll hook him up to an ECG because we use the ECG to trigger the machine, so we can have dynamic gated images. We can image the heart during its beating motion.
How long does usually a stress take, this process, how long does it usually take?
The stress itself, it takes maybe 15 to 20 minutes. If it was done using dobutamine, then it takes longer than 30 minutes.
Okay.
The patient, after the test, will be injected with the radioactive material, which is specific for cardiac imaging. And then the patient will be taken out from the stress room, wait for 1 hour, and then taken to the imaging room. Of course, the cardiac test is done in two steps. The first step is the stress, and then the second step is the rest. And usually the rest is done on a different day. So the patient comes to do cardiac imaging in 2 days. Of course, if the stress test was normal, then he doesn't require to do a rest. And you can see here the patient is being taken on the machine, and the machine usually will rotate to take the SPECT images.
Are there any contraindications? We have the MRI, they're contraindicated if they have some metallic implant. CT are contraindicated if they have RFT. Anything regarding
for nuclear medicine, we don't have any contraindications. We usually will tell the patient to empty their pockets from if they have coins or pen or whatever, because metallic material will attenuate the radiation that comes out from the patient body. As I told you, we give the injection of the radio tracer either by through the vein or orally, so the radiation comes out of the patient. The machine only detects the radiation that comes out of the patient. So if there is any metallic something in their pockets, will attenuate and will give an artifact in the images. And you can see here the technologist is preparing to do the study, and after doing the study, of course, they have to process it using the computer, and then post-processing, we take it to another computer to be reviewed, and we write the report. You can see this is a bone scan has been done to the patient.
So a lot of this is using radiation and gamma and beta. And
Yes.
It's scary to hear all of that in one patient. So
first of all, we use gamma for imaging and beta for treatment. Okay. We don't use beta for imaging at all. Of course, there are some exceptions. We use very little amount of the radioactivity, and usually the doses given to the patient are equivalent to a dose that patient receives when he does a chest X-ray. So there are very little amounts of radiation given to the patient. There are no risk to the patient when doing a nuclear medicine study.
And is there any absolute contraindication for going and
yes, of course. If the patient is pregnant, this is an absolute contraindication. Also, there is an exception for this. If the patient, usually we receive pregnant ladies who have chest pain and they're suspecting pulmonary embolism.
Yes.
So in this condition, also this is an exception. We can do a nuclear medicine study, and still the risk to the fetus is very negligible. We give very little amount of radiation, and there is no harm to the fetus.
Okay.
Any side effects that can happen to the patient after performing such tests?
Yeah, well, because we use tracer amounts, usually there are no pharmacological effect of the dose that we give. It only has the little amount of radiation which can be detected by our machine. Of course, some of the tracers we use can induce allergic reaction, and it did happen. I mean, I've been working in nuclear medicine for 14 years. It happened once in my life, and during this, the patient was receiving macroaggregated albumin, which is used for pulmonary embolism imaging for perfusion scan. And the patient she developed an allergic reaction, and we found out that the patient was allergic to albumin. And MAA is an albumin, so yes, sometimes they do have some allergic reaction.
We can see here some images that for...
Yeah, these are images of the heart, and you can see the heart beating. This is a 3D reconstruction of the heart. And we also have polar maps. This is one of our technologists processing the study. And this sign just tells you that there are radioactivity. And this is the HAT lab, which we prepare the radioactive material for each patient. And this is one of our technologists preparing the dose.
And it's being prepared on daily basis?
Yes, on daily basis. We will have a list of the patient coming because we put the appointment, so we know each day how many patients we're receiving for each study. Of course, there are studies which are done on an emergency basis, and for those emergency studies, we do prepare the dose as required.
Sorry, we have again the same questions coming from one of our viewers. Probably didn't hear the answer. The complications that might, or contraindications, or the safety regarding pregnancy.
Yeah.
Apologize for the repeat question.
Yeah. For pregnant ladies, as I told you, it's considered as absolute contraindication to do any nuclear medicine study, except if the pregnant lady has symptoms of pulmonary embolism. Because then you have to weigh the benefits against the risks. I mean, the risk of the patient, if she has pulmonary embolism, she might die. And the treatment of pulmonary embolism, you have to give the patient anticoagulant.
Exactly.
Yeah.
And there's a risk to the fetus if you give anticoagulant blindly. So you have to know the diagnosis. And the only way to diagnose pulmonary embolism is to do the pulmonary perfusion scan. And we give very little dose, and it has no risk to the fetus.
Another thing that you mentioned is that it can be used to test for H. pylori.
Yes.
So does that mean that we can completely let go of upper GI endoscopies?
No. It does not exclude upper GI endoscopy. Now, H. pylori is the bacteria which, in some patients, can cause the symptoms. Okay. Now, the gastroenterologist usually, when they do the endoscopy, they can take biopsy and they do the flow test. But in some cases, the patient, and usually they will be given the treatment, and then the patient becomes symptom-free. But then if the symptoms come back, usually, and the physician does not want to repeat the endoscopy, he might send him to us, and we use carbon-14. Urea carbon-14 to test for the H. pylori presence. If there is H. pylori, the patient can receive the treatment, eradication treatment for that.
How is the test is done?
Yeah, usually the patient will have to come fasting to our department. He has to stop antibiotics for 1 month. He has to stop the proton pump inhibitors and the the gastric medication for at least 1 week. The patient will come. We give him a capsule which contains carbon-14 urea. The patient will swallow that tablet, and then after 20 minutes, we give him a special balloon. The patient will blow on that balloon, and then we take the balloon to a special machine which will detect carbon-14 presence in the CO2 which was released by the bacteria. The H. pylori will break down urea into ammonia and carbon CO2. CO2 will have carbon-14, goes up through the ventilation of the patient. And then according to how much carbon-14 detected in that balloon, we can know if the patient has H. pylori or not. If the patient has H. pylori, he has to go back to his physician to receive the treatment. If he doesn't, then his symptoms must be because of something else.
And how sensitive is the test compared to flow test and the pathology?
Yeah, no, flow test is the gold standard. Now, our test, you can compare our test to a blood. There is a blood test which can detect also antigen of H. pylori, and our test is you can compare to that test. So and it is very sensitive. There's another test which they use carbon-13, which is non-radioactive. Carbon-13 is also available usually in gastroenterology department, but the machine is more complicated than our machine. So, and that in Jahra Hospital we have both machines. So when the carbon-13 machine breaks down, all the patients come to us. If our machine goes down, then all the patients go to carbon-13. So we are alternating. But our test, the carbon-14 test, is more sensitive than the carbon-13 test.
Okay.
How often can we do or can we repeat tests for patients?
Yeah. Now, the radiation protection department say that the member of the public should receive 1 millisieverts a year. This is above the background radiation. Now, for patient, there is no specific dose. Of course, the little dose you give that to the patient is better, but according to the case of the patient. Now, radiation workers are allowed 20 millisieverts a year. Of course, we don't reach that limit at all. I mean, our annual limit is approximately 1 millisievert a year. So we are on the safe side. Yes. But for the patient, I mean, some patients were required to do multiple CTs, or the patient were required to do fluoroscopy. Now, fluoroscopy is the largest dose that you can give to a patient. Like if you do cardiac angio or renal angio, this is a very high dose. Now, in nuclear medicine, there are some tracers, specific tracers, which are used in oncology, like gallium-67 scan or thallium 201. They give the patient higher dose than the technetium-based tracers that we regularly use during our daily work. But these are, of course, we weigh the benefits of the study against the risks for the patient. So if there are more benefits to the patient, we will do the study. And this is the way that we...
To give an example to our viewer, for example, if they did the stress test, cardiac stress test, what dosage they are receiving in millisieverts?
For a cardiac stress test, we are talking about 2 studies. Usually the dose to the patient will be around 3 millisievert.
3 milli.
Yes.
So this is almost triple the limit for the public.
Triple the limit for the public. But this is the patient. This is the public. And the patient needs the study to be done.
And this is considered one of the highest exposure?
Yes, cardiac is considered one of the highest. There's, of course, as I told you, gallium is much higher. Gallium will give you maybe 7 to 8 millisieverts. But gallium is also rarely done. It's usually done for oncology or pyrexia of unknown origin. And then in these kind of situations,
you need to do it.
Need to do it.
What is the minimust test done with minimal radiation?
The least test that can give you radiation is the carbon-14.
The urea breath test.
Urea breath test. This is the minimum that you can get. Of course, if you're doing VQ scan, doing perfusion only, like for the pregnant ladies, also will give very minimal dose.
What is the role of nuclear medicine and children?
Well, in children, we have a lot of studies for children. I mean, we do studies from day 1 after birth. Some patient will come to us, like we do the HIDA scan, which is the hepatobiliary study for patients, for neonates, usually with jaundice, to know whether it's obstructive jaundice or there is biliary atresia. We do studies for the kidneys. Usually the patient, and on the antenatal clinic, they will say, okay, there are some malformation of the kidneys, and then after birth, they will send us the patient to do a MAG3 study, which to detect the function of the kidneys. If the patient has UTIs, then usually they bring the patient for us to do a DMSA study, which to detect the scarring in the kidneys. We do also bone scans for the pediatric department to detect osteomyelitis or septic arthritis in the joints. And these are the main ones that we do for pediatric cases.
All right. I think there's a new machine, or like there's a video that we would like to have your inputs on. So can we show that, please?
Yeah, this is our new PET-CT machine. Currently, there are 4 machines in Kuwait. The first one was installed in the Kuwait Cancer Control Center in 2008. The second one was in Mubarak. Third one in our department. There's a 4th machine which is in the KFAS, Kuwait Foundation for Advancement of Science. It's called the Sheikh Jabir Al-Ahmed Molecular Imaging. So our machine it's still under installation. It's not fully functioning yet, but hopefully it will be functioning after 1 month. And then using that machine, this machine is a positron emission tomography. We use matter-antimatter reaction, and we use positron, which is an antimatter to the electron. We inject it to the patient in a form of FDG, fluorodeoxyglucose, and it's a form of sugar. And usually this test is mainly used for oncology and cancer cases, and also it could be used in paraxia of unknown origin.
And you use both PET scan and CT scan together, right?
Yes, this machine is actually 2 machines in one.
Yeah.
It's a 64 slice CT, and it's a PET CT. So it's a PET machine, so it's combined.
So give the patient a higher rate of sensitivity?
Yes, we use the CT as for morphology and anatomy, and we call it for attenuation correction and localization. And the PET machine will detect the function, and then we combine both images. And we fused both images, and we can and this will give us more sensitivity and more contrast and more specificity also.
And
to
is
detect
there
diseases.
Sorry, is there any contrast injected, for example, in patients with renal function impairment?
Yeah, usually in our department we don't give IV contrast, but we are trying to collaborate with radiology to use the machine even with contrast. So we avoid doing 2 tests for the patient. So if the patient needs CT with contrast and the patient is going to do a PET CT study, then we can cooperate with the radiology and we can do it in one study. We'll do PET CT with contrast, and then both doctors will be happy, the patient will be happy because he received less dose. It will be done as one study instead of doing 2 studies.
Yeah, it will save
All
time.
right. So we're unfortunately running out of time, Dr. Mahmoud. Thank you very much for accepting our invite to our show, and we really hope to see more of you soon.
Thank you very much for listening to me and giving me the chance to give some information about nuclear medicine to the public.
Thank you very much.
Thank you, Dr.
Thank
Mahmoud.
you.
Nice to meet you. Thank you.
So our next report was shot last week, and it was about a dental symposium. So let's take a look.
Dr. Daniel Jafic, consultant of prosthodontist, and I'm clinical director of dental department in New Morsad Hospital. Aim of this symposium is just to bring the latest technology and latest treatments in aesthetic and implant treatments in dental field. And we are very proud in Morsad Hospital that we brought one of the biggest experts in implant and aesthetic dentistry. Today is day of implant dentistry and placing implant in aesthetic zone. So we brought expert from Germany, Dr. Marius Steigmann, professor. He's a visiting professor for many universities in Europe and States, and he's one of the leading implantologists in Europe and worldwide. He's presenting just now the latest technologies, where to put implant and which kind of aesthetic impact it will have. Next day, tomorrow, we will bring another expert in aesthetic dentistry. This is Dr. Galip Gurel. He is from Turkey and as well visiting professor in New York University, Kentucky University, Marseille University in France, and Yeditepe University in Istanbul. Dr. Gurel is an expert particularly in veneering and aesthetic dentistry. That means correcting all malposition of teeth, discoloring teeth, fractured teeth, even missing teeth.
Mohammed Abdelaziz, the operation manager of Noon Medical Company. We are a silver sponsors for this symposium for today. Our company, one of the latest company all over Kuwait, started before around 10 years ago, and our brands include all the materials the dentist may need it through the procedures of the treatment. Starting with the implantology, and this is our topic of the presentation or the symposium for today. We have that system, it's a Korean system. The first, we faced a problem in the Kuwait market about the Korean, but once the dentist tried and evaluated, they liked it so much because it's very simple. Most of the patients all over Kuwait afraid of the implantology names. This is the implant that you screw it inside the bone, and some bullshit said that it can make a cancer in the patient, and this is not true, by the way. But it's make it easy for some patient who's used a denture before and it's immovable, not feeling comfortable through eating and through his meals over the day. Now with the implant, he feeling with something fixed in his tooth, same like the natural teeth.
Welcome back to our show. Now we will meet with our second guest, Dr. Abdurrahman Al-Anazi, ENT department in Jahra Hospital. Welcome, Doctor. Can you introduce yourself to our viewer?
Yeah, sure. Good evening, and thank you very much for this opportunity.
You're welcome.
It's truly a wonderful chance to bask in the ambience of such a warm presence and such an informative TV show.
Thank you.
So, briefly speaking, my name is Dr. Mahmoud Alfeeli. I am an honors graduate from the Royal College of Surgeons, currently an ENT resident in Jahra Hospital, and I'm also an instructor in advanced trauma life support, an instructor candidate in care for the critically ill, surgical patient, and instructor potential in emergency management severe burns in the United Kingdom. And if I would talk about my department, Basically, we are a fully independent department. The ENT, or the otolaryngology head and neck surgery department in Jahra Hospital, is a fully functional independent department. We have a faculty of about 30 doctors, and the head of our department is our fearless leader, Dr. Antoine Brook, who's one of our pioneers, let's say, in our region.
Okay.
And what's unique about Jahra Hospital is that we do have an amalgamation of different people from different backgrounds. So, for example, Dr. Brook was specialized in France and with the European Board and Fellowships in head and neck and facial plastic surgery. And Dr. Adari, across the Atlantic, she finished from Ottawa, and she is interested in rhinology. And of course, it is a very proud moment for us when we have a homegrown Kuwaiti resident, our senior Dr. Mohammed Bouabbas, who is working with us in the hospital.
So, for the viewers to understand more about the specialty itself, ENT, it mainly deal with ear, nose, and throat. But for common people, they will think that it deals with rhinoplasty, tonsillectomies, basic ear problems or throat problem. But it's it's more broad and more and deep specialty.
Exactly. That's a very, very valid point. ENT is such a multi-diverse specialty. It's basically, after we finish our ENT training scheme, there's about 8 subspecialties that we can go into. You can go into the pediatric or the children diseases in the otolaryngology. You can be into facial plastic surgery. You can also be in head and neck surgery, and you also can be in rhinology and sleep studies as well. So it is truly a multidisciplinary specialty. That's right, because we do a lot of our work is in close liaison with all the different specialties. For example, if we have a child, we would work in close liaison with a pediatrician. If we have, let's say, a thyroid case, it's something that you and I would share our expertise on. So that's what's so interesting about the specialty, because tonsillectomies and tonsils and all that, these are minor surgeries that we do. But the thing is, in our hospital, we have a great emphasis on 2 things: facial plastic surgery, and the second thing is head and neck surgery. And we do have annual workshops, about 3 workshops per year, and they're being led by international speakers and professors in their own right. And it's a great setup, to be honest.
What are the common problems that come across to your practice on daily basis? The main bulk of cases that you see. We know that every specialty they got around 80% of something that is recurrent.
Okay, so when we talk about common ENT cases, these are the cases that we all know. Sinus problems, ear infections, all that. However, most of the time, patients do have a sound knowledge about, what that disease entails. But if I may, today, if we could talk about neck lumps or neck swelling, because these criteria, or these group of patients, these are the most distressed patients that present to our OPD, and they do present with a quite considerable number. You have someone who noticed swelling in his neck or in any of this region over here, and he doesn't know what that entails. What does that mean? And so when we have them coming to our setting, they fear the worst initially.
Exactly.
And so the point of this is just to create a bit of awareness. I mean, Dr. Mahmoud did an astounding job, with talking about thyroid scans and PET scans and all that. And nuclear medicine is something that we do depend on certain cases. So let's say if someone, only recently, someone presented to our OPD clinic, and he noticed a neck lump. Okay, so this neck lump can mean a lot of things. And if we go to and this neck lump was just in the middle of his lower neck. Okay, so that's where the thyroid gland is.
Yeah.
So when we talk about thyroid glands, and some people sometimes have a misconception. This is a tumor straight away, but initially there are a lot of reasons why this swelling would happen. You know, if let's say if we talk about the gland itself, if it's hyperactive or if it's hypoactive, so if it's producing a lot of the hormone,
Yeah.
then you would have, you know, problems in dealing with that. And Dr. Mahmoud, you know, he mentioned Graves' disease, which is an autoimmune disease. Basically, it means that your body creates a mimicry kind of thing that will stimulate your thyroid gland to produce this hormone, and then, you know, you will get this enlargement. Another thing would be, you know, sometimes for some reason, you know, the thyroid gland, a part of it will seal off, will create a wall on its own, and it will be hyper-functioning as well. And that's the, you know, the adenoma, which is the non-cancerous growth. And then a third thing would be basically, you know, sometimes people have an abnormal growth in the thyroid gland itself. So, you know, with all these patients that come with neck lumps, patients would come, you know, with swelling that they notice near their chin or on their cheeks. You know, there's a systematic way to go through it. And, you know, I come from a school where, you know, medicine is not a paternalistic discipline. So that means, you know, the day where the doctor knows best are gone.
Yeah.
It's a partnership.
Yeah, exactly.
So that means it's my duty, my responsibility to inform the patient, to discuss with the patient, to reach an agreement with the patient. See, I can't tell the patient just do this, do that, and then come back to me. I have to explain why am I doing that.
Yeah.
And you know, as you know, sir, you know, whenever we investigate someone, we do have a protocol, we do have a criteria that we do. We go from the simplest things, initially a blood test, and we escalate to radiological investigations, and then, you know, we have functional investigations, and then if need be, we have invasive investigations.
But excuse me, we have a question from our viewer, Jabir. He was asking regarding, so many people are having dizziness or giddiness, okay, and associated with nausea and nystagmus, or feeling that the eye is moving around. What is the cause of it, and what is the cause of imbalance, and is there a treatment?
Okay, so if we're talking about dizziness or, you know, vertigo, we have to go to the basis of it all. So we have the cochlea, which is the apparatus that's involved in the balance of, you know, of the human being. And, you know, dizziness does have a lot of
differential diagnosis.
Differential diagnosis. It's quite a broad differential diagnosis, and, you know, it can be dependent on, is this something that happens within minutes or within hours or within days? When you get this dizziness, does that mean, you know, do you also get nausea, vomiting, headache? Do these all subside? Do you have earache? Do you have problem with your hearing? Do you have you know, tinnitus or this buzzing noise? So the differential is quite, you know, quite broad. And, you know, patients who do have vertigo, dizziness and all that, they do warrant investigations, and it's a case-by-case kind of idea. So they would go to the doctor himself, and they go through a full clinical examination, and then, you know, most likely, you know, order an audiogram and do a number of tests, and then they'll get to the root of it.
And the treatment based on the cause of it.
Exactly. Yeah. Exactly.
And I think we have a video of a procedure that is done in your department.
So if I think, yeah, the video that we're showing is basically a thyroidectomy, removal of a thyroid gland. And as you can see, the labels are in French, which shows how influenced we are in Jahra Hospital with the French culture. And basically, you know, the incision that we see in this patient is basically an incision about, you know, 6 or 7 centimeters. It's located somewhere which is cosmetically convenient. So, and the skin creases. And what we do is, you know,
but excuse me, it's for viewer distraction. This
is not for the faint of heart.
Yes.
This is not for the faint of heart. Exactly. So, but just basically for our viewers, what we do, we go from skin, and then we go layer by layer, cutting through, you know, the fascias or the layers, until we reach the thyroid gland in itself. And then after we visualize the thyroid gland, we have the blood vessels that we have to tie off. And then we free the gland. And then, there is, depending on the surgery itself, are we going to remove half of the gland? Are we going to remove the whole gland? Yeah, and it depends really on the indication for the surgery itself.
And let's say if you had to remove the whole gland, the patient post-op or post-operation, they will be on replacement.
They will be on lifelong thyroid replacement, because this is the gland that will produce this hormone. So if we remove it, we will have to replace the missing hormone. And if you think of it, even though it's basically a gland which weighs 1 ounce, but it has such an impact on our lives. It's it's the gland, it's the hormone that basically utilizes all our nutrients and metabolizes everything and gives us the energy that we need. So it's a very, very important. So and sometimes patients who we give these treatment to, so the thyroxine hormone replacement, and it's more of a tapering kind of thing. So every individual have his own kind of niche where he wants, where he needs this level to be up, and we kind of monitor this. And since we're mentioning about the surgery, there are other complications that the patients should be aware of, and I'm sure these are things that we do come across, but hopefully it's just infection or something like that, which is very, very reasonable, and it might happen and we can treat these. But important complications of a surgery like this would be if we put the second video, if we can show the second video, it shows how we're trying to expose a very important nerve, which is the recurrent laryngeal nerve. Now that's the nerve involved in the voice box.
Yeah.
So we have to be very careful when we're moving the gland around this nerve, because if this nerve comes to harm, then it has an implication. But this is very, very rare. We don't have in Jahra Hospital, touch wood, we don't have any of these cases. Okay, and it comes back to expertise. And another thing, we use nerve monitors. So.
This is the second video.
Yeah, that's the second video. Beautifully dissected, I might add. And it's just basically we're just trying to expose the recurrent laryngeal nerve, and as well we would expose the parathyroid gland, and these are really small glands. But as well when it comes to the body, sometimes the smallest things have the greatest impact. And sir, as you know, like if something happens to the parathyroid, what would be a complication that would happen after?
They have calcium imbalance.
Exactly. Yeah. So the patient will be having tingling and all that, but it is easily treated.
Treated, yeah.
Especially in our facilities.
Yeah, yeah. With availability of different types of medications. And
exactly. Yeah, exactly. And I'm sure in Barak Hospital, you guys do a splendid job.
Thank you. Now this is procedure, the continuation of the same.
Yeah, it's the same procedure. It's just now they're removing the whole gland, and basically we do these kind of surgeries in our setting. These are what we call the major surgeries. So we do about 2 or 3 a week. So we do have a good number. Because of the catchment area that we have, I see it as quite a decent.
This surgery is considered to be the battlefield between general surgeon and the ENT surgeons.
Yeah.
Because general surgeons tend to do them, and the ENT surgeons.
Well, actually, sir, that's a very, very interesting point, and it's a very good point. And I would like to go back to a week ago. I think it was a week or 2 weeks ago. The general surgeons had held a workshop, a head and neck workshop, in Marina Hotel, and it was, by the way, that I have to thank them for that, because it was truly, truly a splendid, experience. And they brought Prof. Cyrus, and he was a maxillofacial surgeon. And I remember I think I was the only ENT guy there, and I was sitting and. We were chatting with him, and he was saying, so in the introduction, he was saying, so in the UK, 95% of head and neck cases are done by maxillofacial and ENT. and only the older surgeons are doing that. That being said, as a peace offering from our side, I formally invite you to join us in our hospital in any of our procedures, and you're more than welcome. But the thing is, for ENT, it's like the head and neck, it's like the promised land. You know what I mean? So we are very thrilled about it, and and the thing is, because we do have certain things that we like. If you need a neck dissection, of course, to our viewers, this is quite an advanced thing we're talking about. But there are certain procedures that a head and neck surgeon
can do better.
He's more comfortable. It's more in his field of work. Exactly. For example, and now I'm gonna go to the plastic surgeons. So, for example, a plastic surgeon does an amazing job. God bless him. He does breast augmentation, tummy tucks, and you name it, he's there. He's doing it. And then the ENT surgeon, the facial plastic surgeon, is only concerned with the head and neck region. So this is the thing. You can be a jack of all trades, which is fine. Some people are splendid and spectacular in that sense. For me, I like to be concise. I like to focus on one area.
More specialized.
So like, for example, if you have a sick patient, you send them to the general medicine, general physician. Sometimes you do need a cardiologist opinion. Sometimes you do need a gastroenterologist opinion. And this is the relationship between you and I. It's the same thing.
I think we have some images that we would like to have some comments on them.
Yeah, basically this is another thyroidectomy that we did. It was 2 weeks ago. You can see the nerve monitor. That's the incision I was talking about. We kind of utilize the skin creases to make it more cosmetically pleasing. And as we said, we go layer by layer, taking care, trying, minimizing bleeding to the maximum of our efforts. So if we just keep going with the pictures, it's just, showing you the next picture, if we could, that's the one. See, layer by layer, and the next picture, until, the next picture would show us just even more, the thyroid gland itself, because now it's just the fascia on it. So now it's just, we're dissecting it. Okay, we're dissecting the fascia above, and we're reaching to the thyroid proper. And if we go to the fourth picture, see, now there you have it.
The gland is showing.
And we said this is a small gland, but you can imagine this lady presented with obstructive symptoms. So the swelling was so big, it was compressing, and making her, giving her breathing problems. And if you have the last one, that just shows you we removed, the first half, and we're going to remove the second half. So.
And when is it needed to keep the second half of the gland?
See, nowadays there's a trend into more radical surgeries. But if you have a pathology that's concise to one lobe, it's under the surgeon's discretion. Sometimes they just do a partial. They just take one lobe. Sometimes they take both. It depends really on the pathology that's going on.
So basically, it's case by case, depending.
Exactly. See, we say medicine is a science, but from our experience, it's not really an exact science, because at the end of the day, we deal with human beings, and human beings have their imprints and have their variations, and it's really, we have protocols on how to manage things, but essentially, it's a case by case thing.
Yeah. I think we are approaching the end of the show now. It was really a pleasure to have you here, Dr. Abdurrahman, with us, and we hope that we will meet you once again in your field.
Sir, the honor is all mine. And
thank you.
Thank you very much.
Thank you very much. We thank our viewer today, and we hope to meet you next week. Have a good night and enjoy your week.